Okay, y'all, part two. So covering the two article readings for this week. The first is current perspectives on psychedelic therapy, use of serotonergic hallucinogens in clinical interventions. So there was a little bit of overlap in terms of the readings. My hope is that you learned a little bit because they were a little bit like you learned different things because they were a little bit nuanced, but I'm going to cover the portions that are more novel in this article. So the first is the application of existing evidence-based models to the use of psychedelic therapy. So in our study, we used a CBT model because that is in many ways standard practice in addiction treatment. So as we know with CBT, that's the examination of maladaptive thought and behavioral patterns. And the thought is that psilocybin administration helps facilitate altered cognitive and emotional states in essence, kind of altering that roadmap that we have talked about in the past. Same thing here, psychedelic effects aid in reframing detrimental schemas and self-identity constructs. So it works really well in alignment with the approaches of CBT and the purpose and the hopes of CBT. Another application, motivational enhancement therapy, again, application with addiction. This enhances motivation to change problematic behaviors or more maladaptive behaviors. So those two approaches are a good fit with psychedelic approaches. Some synergies in psychedelic therapy. There's post-acute changes in brain connectivity and enduring increases in mindfulness-related capacity. So the thought is with psilocybin, with psychedelics, if the brain is already in many ways kind of primed to do this, that is why in the last presentation, I talked about mindfulness as a tool in integration because psychedelic assisted therapy lends itself well to mindfulness-based approaches because it primes the brain for that. There's the potential integration of acceptance and commitment therapy or ACT or mindfulness-based relapse prevention because of the synergies of the tenets of those approaches and what psychedelic assisted therapy can do. So these effects of combining mindfulness-based interventions with psychedelic administration allow for the exploration of novel and effective models of psychedelic therapy and the application in conjunction with one another. So I just wanted to point out like 4 approaches that we at the very least have been exposed to. We know some of the language about, and so potentially a direction of research would be understanding how approaches like ACT or mindfulness-based relapse prevention could be applied with the use of psychedelics because they're not used so much. CBT and MET really are what are being used. So we know this, but I'm just giving you a little bit more evidence here of epidemiological and survey studies show therapeutic potentials of psychedelic use independent of therapy. So there is some evidence to show that psychedelics on their own can have some benefit, though we're learning that that is not the most effective way of using it. Associations between psychedelic use and reduced recidivism, suicidality, and psychological distress have been found. These are in, so for example, my mentor at UAB conducted a study where they looked at a data set from the like criminal justice system in Birmingham. And they saw that individuals who had recreationally used psychedelics had lower rates of recidivism in the criminal justice system or in the criminal system. So there's just some it's in many ways like kind of a secondary data analysis of psychedelic use that shows that there's some positive outcomes with that without therapy being adjunctive at all. And to therapy, yeah, with therapy and psychedelics not being used together. There's reports of tobacco smoking cessation attributed to psychedelic use. That's research coming out of Johns Hopkins as well. Psychedelics have therapeutic value as pharmacotherapies independent of structured treatment intervention. So again, there's different fields that are doing studies on this, not just mental health. So physicians, other people are doing studies just to show that in many ways it is just a generally beneficial adjunct to life. Maximizing therapeutic benefits by incorporating psychedelics within structured, evidence-based psychotherapeutic interventions is what has been shown to be the most beneficial, and that's where the majority of efforts with psychedelic research is. So I wanted to give you some more like specific dosages. I know I talked about dose, but I did tell you I'd get a little bit more specific here. So these are kind of like the estimated doses that are being used in research right now. So with psilocybin, it's 20 to 30 milligrams for 70 kilograms of how much somebody weighs. So we use 25 milligrams for 70 kilograms. That found that there's benefits in life satisfaction and well-being. For LSD, the lowest detectable dose is 20 micrograms with the optimal therapeutic window estimated to be between 100 and 200 micrograms. With mescaline, studies have used doses that range from 200 to 750 milligrams, with 500 being a common research dose. In ayahuasca, DMT doses range from 0.6 to 0.85 milligrams per kilogram in freeze-dried capsules, or approximately 0.36 milligram per kilogram in a liquid brew. So weight-adjusted dosing is commonly used, but there's a need for optimizing safety and efficacy, like that's still being a concern, and also not totally sure if weight-based dosage is the best. So more specificity in the screening process. These are very common reasons to screen somebody out of a study. So remember, in many ways, we're still in like a proof of concept form or stage in our development as a field. And so our screening process is quite thorough, as it should be in any study, but the reasons for exclusion are quite a few. So remember that it's politically charged. We're still trying to prove, we're still trying to understand, are there any interactions, for example, with history that we should be mindful of? Is there the possibility of doing harm? Like, let's be vigilant. And also in many ways, this is informed by, IRB boards. I know that was redundant. Institutional review boards that are trying to protect participants, research participants, as well as institutions that are really trying to minimize any sort of liability. So remember, all of this research is being done primarily within some kind of institution, mostly academic institutions. So exclusion criteria: personal or family history of schizophrenia, psychosis, mania, or severe personality disorders. In ours, it was if you shared 25% of your DNA with that person or more. Consideration for potential exacerbation or increased risk. If you have had recent suicidality, drug or alcohol use disorders. This is for some of the other mental health screenings, because it's used to treat these. So of course, the recent diagnosis, that would actually be an inclusion criteria. Any sort of dissociative disorders, past trauma. To my understanding, these are just considerations that wouldn't necessarily exclude somebody, but these are things that you would look potentially a little bit more closely at. So there is some exclusion based on medical conditions any sort of neurological disease, poor liver or kidney function. So again, we're just, if you think about what's the purpose of a liver or kidney, it's a filtering system. So is that potentially affected in any way? Will the psychedelic affect that, or will that affect the psychedelic experience? Uncontrolled hypertension. Psychedelics are known to temporarily elevate heart rate and blood pressure, primarily blood pressure. So if you're on the cusp of hypertension, we are very vigilant in making sure that that person is monitored in the study. We had a blood pressure cuff on our participants the entire time, and we tracked it every 30 minutes for the first 2 hours of the session, every hour for the second 2 hours, and then every 2 hours for the last 4 hours of the session. But if they have severe hypertension, they will be excluded, and then current pregnancy or nursing. Other things to consider. So if they're taking any serotonergic medications like SSRIs, the psilocybin is not going to work. Like anything that works on a 2A receptor, or any sort of serotonin receptors, or 2C, that's not going to work. Tricyclic antidepressants, MAOIs, and certain antipsychotics, those could interact negatively with the psychedelic, or just in a way where it doesn't, like the mystical experience can't happen, things like that. And then screening criteria may become less restrictive as we gather more empirical findings on safety and clinical potential. But right now, we're just being very vigilant. So some future considerations in this, continued research needs to be done to refine dosage, guidelines for different fit psychedelic compounds. Again, we're taking our best educated guess at this point. Exploration of individualized dosing based on therapeutic goals and patient characteristics would be an area of future research. Refinement of screening criteria to balance safety considerations while also being able to expand access to a greater number of individuals. Absolutely is a priority in this field. Having collaboration between researchers, clinicians, and regulatory bodies to establish standardized dosing and screening protocols would be helpful. Because again, a lot of the fear in this is based on people who have no knowledge of this work. So hopefully they'll be open to being informed and educated. The monitoring of potential drug interactions and the development of guidelines to ensure safe administration of psychedelics. Of course, so more is needed to be known about potential drug interactions with psychedelics. So I'm going to talk a little bit more in detail about setting here. So this is what safety measures and creating a safe environment is. So drug sessions take place in a comfortable living room-like setting with evocative artwork and a reclining sofa for the patient, or a bed, just someplace where the person can be comfortable for 8-ish hours. Then therapists should be comfortable sitting nearby throughout the session. We were in like plastic chairs, but we also had like little footstools that made it a little bit more comfortable. Private areas are preferred with access to a dedicated restroom. Many of our participants in our study within the first hour was like, I have to pee. And we hypothesized that was them starting to feel the effects and like getting a little bit nervous. But we had a private restroom for them, which I think was really important for our participants. Physicians are available on call during sessions with rescue medications if needed. We had physicians on call. We were in a hospital. Regular blood pressure monitoring may be implemented during sessions to ensure safety. Like I said, we did that at differing intervals throughout the session. So integration and ongoing support. So a little bit more information here about that. Integration is a vital part of the psychedelic therapy and includes ongoing aftercare following drug sessions. That's integration. And then many of our participants asked for, like, in the future, so we asked for feedback on ways to improve the study, that there would be boosters even farther out from the study. Like, so we did that up to 6 months, or we did our integration up to 4 weeks after the drug administration. And then we did follow-ups up to 6 months after drug administration. And our participants wanted more than that. Just FaceTime with us, unfolding of new insights that they wanted some time with us. We made ourselves available, but that was all that was included in the protocol. Follow-up meetings between patients and therapists occur 1 to 2 days after the session to discuss the experience in more depth. That's what we did. We also had some like guided interviews for us to get hopefully a more broad understanding. But remember, we didn't want to influence their narrative, so we did ask them to just say whatever came up for them, and then after they had the chance to share their story and what was important to them, what they found out, that's when we were asking some more probing questions about their experience. Integration process can continue on a weekly or bi-weekly basis, meetings for 1 to 3 months. After we did it for 3, depending on treatment goals. Patient and because our treatment goal, it was to stop using cocaine or to decrease the use of cocaine. And then patients are encouraged to expand upon and interpret their psychedelic experiences during integration. Written narratives and artwork can aid in solidifying insights gained during the session into lasting trait changes. We encouraged either of those, any sort of kind of creative expression of what happened for them. And then I also, in this article, just wanted to highlight some of the types of psychedelic experiences. They talked about sensory aesthetic experiences that had these 5 characteristics to them: psychodynamic autobiographical experiences, which that was a lot of what our participants experienced. Cognitive intellectual experiences, our participants really didn't experience that. They experienced sensory aesthetic experiences, psychodynamic autobiographical experience, symbolic archetypal experiences. I would say maybe a fourth of them had challenging experiences, and all of them that experienced the psilocybin sessions had what would be considered mystical experiences. So they can be in conjunction with one another. So these aren't mutually exclusive in any way. You can have all of these throughout a session, but I would say the cognitive intellectual experiences were like the least common in ours. Okay, finally, talking about psychedelic harm reduction and integration, the trans-theoretical model for clinical practice. This is an application pretty exclusively to substance use. So some principles of harm reduction. So this is in many ways like a response to abstinence-based models, but also remember that abstinence can be a harm reduction approach. So they're not mutually exclusive. They're not in competition with one another. This is just a different way of approaching addiction. So harm reduction psychotherapy is a non-judgmental stance towards substance use. This is extremely important, in my opinion. People don't get shamed out of their use. They don't get enough like finger wagging, like if only you would finger wag me just a little bit more, then I would stop using. So this non-stigmatizing, non-pathologizing, non-judgmental approach to drug use is central to the harm reduction model. And it is an approach that I believe in very strongly. It's a shift from traditional abstinence-based paradigms, but also remember, abstinence can be a harm reduction approach for some people. There's an emphasis on the therapeutic alliance and patient empowerment, client empowerment, and what the therapist should embody is flexibility, honesty, warmth, and respect. So these are some tenets in how you position yourself in that space. So some techniques, there's incorporation of relapse prevention techniques. So this is important. We would always differentiate with our participants the difference between a relapse and a lapse. In some ways, it can be just semantics. In other ways, I do think that they can be fundamentally different from one another. So relapse is in many ways, a complete return to previous behaviors and patterns. And a lapse is a momentary return to that. So we believed in, and I still do in our approach, this is what we use, that lapses were actually really important. They were learning experiences, and many of the lapses for our participants really solidified their desire to decrease or stop use. Their skill building and active strategizing. So you're trying to equip the person with like real life tools to apply and incorporate when they employ, I guess I should say, when they are in a potentially triggering situation. Urge surfing as a coping mechanism. So recognizing that when the urge to use, the urge to buy, the urge to gamble, the urge to self-harm, it's like a wave where it comes to a crest and then it falls. So there's building tolerance and the recognition that these urges will pass. So building tolerance for the recognition that like, I can get through this. I don't have to indulge this urge, and building some confidence in that. Exploring multiple meanings of substance misuse. One of the things that we would do is we would say like, what do you like about it? And sometimes our participants were like, oh, can I say anything about that? Like that feels kind of counterproductive to the treatment. But if we're not talking about the purpose it serves in the person's life, then we're not getting a full picture of the use. Comprehensive approach combining humanistic, cognitive, behavioral, and psychodynamic perspectives. So that is what encompasses harm reduction, the harm reduction psychotherapy model. So attitudes of working with non-ordinary states of consciousness is mindful based. With this approach, there are mindful based treatment modalities that are incorporated. Again, with non-ordinary states of consciousness, we are encouraging non-judgmental and open curiosity toward experiences, cultivating non-judgmental attitudes in us as a therapist or as the guides. There is, in terms of the attitude with working with NOCSs, there's similarity between psychedelic experiences and meditation. It is like a deep sense of presence in the moment. And then, like I said, we are embodying as the therapist and hopefully modeling for the client patient participant in a non-judgmental curiosity in whatever comes up in their experience. So here's the framework for understanding the benefit of loss of sense of self. So this is valuing that ego dissolution in psychedelic experiences. Ego dissolution or ego death is a huge part of this, because in some ways it's like a snake shedding its skin. We're trying to kind of like shed some old behaviors, shed some old schemas, shed some old self-concept, hopefully opening up opportunities for a new way of seeing yourself and a new way of navigating the world. So traditional psychotherapeutic approaches focus on ego function. We know that from psychodynamic, id, ego, superego, right? Mindfulness-based modalities also have, so you're combining with psychedelic experiences, this mindfulness-based modality, a deep presence, engrossing yourself in the moment, and then a value for ego dissolution, because quite frankly, that can be terrifying in psychedelic experiences. Many people experience that as they watch themselves melt, they watch themselves light on fire, so it's these like very clear tangential or tangible experiences or witnessing of something changing dramatically in their body. So they're watching themselves melt, they're watching themselves light on fire, and it's just scary, especially if there's still any part of you that's like not sure about the experience, and you're fearful, like, oh my gosh, am I going to come back from this? Ego dissolution is a stage of development and reduced distress. So it's a stage of development in terms of in some ways the stages in a psychedelic experience, but it does also hopefully indicate a little bit of reduced distress within the experience and openness to that happening. There is a non-pathologizing approach to ego dissolution experiences, and quite frankly, it's super encouraged. That's one of our hopes for our participants. And then the potential benefits of ego dissolution, which I talked about, which, shedding of old self-concepts, shedding of old schemas, all of that kind of stuff. So when you're working in non-ordinary states of consciousness, you want to facilitate insight. There's inquiry as a component of mindfulness-based interventions, just being curious. You're positioning yourself as having non-judgmental curiosity and open-minded listening to your participants, volunteers, clients, and then avoiding unsolicited advice and interpretations. This is super discouraged with psychedelics, particularly when the person is in the moment, like they're in a non-ordinary state of consciousness. Again, let their intellect have the day off, give them a break, just let them be in it. Just let them experience. You're focusing on their experience, solutions, and intuition, or they're focusing on that as well. And then remember, any of the interpretation, any of that analysis, that can happen the next day after the experience. And the development of insights are consistent with the psychedelic experience. That's a really common outcome of or experience within psychedelics, is that they're gleaning insight. So the approach to working with somebody in a non-ordinary state of mind is a non-directive approach, like we talked about, client-centered, Rogerian, patient's autonomy in determining disclosure and decision-making. So we always gave them the ability to share with us whatever they want and holding whatever they don't want with themselves. Sometimes they would I guess in some ways kind of hesitate, because they were like, I just have no idea what this means. And sometimes the disclosure in some ways is just limited by vocabulary. Again, that ineffability is a key component of a psychedelic experience, and that means you don't have the words to describe it. So you want this, there's a therapeutic presence in building trust. We know that the therapeutic alignment is paramount in this approach. We want to encourage an inner directed approach, like looking inward and having that, looking inward during the experience to glean insight, and then valuing the inner healing intelligence and patient's intuition. So you are just letting them lead, and you are just there as a grounding source, as a reassuring source, hopefully as a source of safety if needed. Because again, all of our work is done in preparation. All of the clients, participants, patients' work is done in the non-ordinary state of consciousness. So understanding psychedelic harm reduction and integration. So this is rooted in the principles of integrative harm reduction psychotherapy, IHRP, and informed by psychedelic assisted therapy. So it's the combination of the two. It focuses on the unique needs of individuals using psychedelics outside of legal therapy contexts. Understanding how that can be used, leveraged, used to a benefit, supports exploration and understanding without promoting or administering psychedelics. So it's a model that where psychedelics can be used as an adjunctive therapy, but this is a model in and of itself that can be used without any use of psychedelics. Addressing co-occurring mental health issues and processing challenging experiences. So again, if they're not using this, if they're not using psychedelics in a legal therapy context, you still are offering the opportunity to process anything that they may have gleaned from that experience, because we can't control what people do outside of what we have control of. This aims to merge the psychedelic experience with daily life for improved well-being. So that's the PHRI model. So PHRI is a perspective that therapists of all backgrounds can incorporate into their practice. Again, it's just a positionality. You don't have to be part of psychedelic assisted psychotherapy to do this. This is influenced by PAP, IHRP, which again is integrative harm reduction psychotherapy, psychodynamic therapy, and mindfulness-based intervention. So it's inherently an integrative model. It emphasizes safety, rapport, empathy, and positive regard in therapy. So again, a positionality. Therapists can blend their theoretical orientations and treatment modalities with PHRI. And then PHRI serves as an adjunctive approach working with people who have had psychedelic experiences. So it's twofold. Who might benefit from this? So who's like the target population? Individuals who have used psychedelics to address psychiatric symptoms, but again, maybe not in studies, because that's really the only place that you can use this. Those experiencing psychological distress after ingesting psychedelics, having a challenging experience, individuals unaware of the potential risks associated with psychedelic use. There aren't very many, but again, we're not sure about the ways in which it interacts with different medications people are taking. And that's one of the main, considered a risk area. Therapeutic tasks of PHRI encompass both pre and post psychedelic use. So again, it could be used in preparation of and in integration. It provides support and guidance for each patient's unique needs during preparation and integration session, which is best practice. So tools for maintaining benefits, you want to encourage activities like journaling, meditation, and artistic expression to sustain focus on psychedelic experiences. So this is, where they've had the psychedelic experience and now they are no longer in a non-ordinary state of consciousness, and you're wanting them to kind of dive back into that experience without the use of psychedelics, but they're, kind of revisiting that experience and seeing what kind of insights they can glean and what they can take from that. You want to move awareness from an intellectual framework to a holistic framework incorporating the body. Hopefully that's been drilled in you enough. You want to aim for long-term change by embodying insights gained from the psychedelic experience. We talked about that as like actionable steps to take to incorporate and employ the insights that were gleaned. Support patients in finding activities that help integrate and maintain the benefits of their psychedelic journey. So remember, particularly for people who have been struggling with addiction, this can be super important in just like giving them new hobbies, giving them like new meaning and purpose, fostering a sense of continuity and lasting transformation in patients' life through support systems, through integration into other activities, and integrating insights and seeking support. You want to encourage whoever to incorporate insights gained from the psychedelic experience into their values and goals. So not just behaviors, like who do they want to be? How has their self-concept changed? Let's do a reevaluation of your values. Address past traumas or ongoing psychological issues through specialized or intensive therapy, best practice. That's why you should be trauma informed and confident in that. Help patients seek new avenues for support and expand their community of support systems. I cannot emphasize enough how important they are post any sort of treatment. Support changes in daily living, such as career path, diet, or living arrangements to align with their needs and probably newly realized goals and values. Tailor recommendations to the participants' specific problems and concerns, best practice here. So basically it's saying like, it's not a one size fits all. Don't just, don't just use the psychedelic and then apply the same stuff to everybody. It should be a very tailored experience. So some broad implications of this model: this challenges abstinence-based paradigms that discourage or stigmatize drug use. Again, it's meant to be it's non-pathologizing, non-judgmental. It shifts the role of the clinician to support, to follow the client's preferences, aligned with harm reduction principles as outlined here. Redistributes power dynamics and challenges oppressive patient-clinician relationships, so wants to be more egalitarian in this, more collaborative. It provides a model for therapists to work with patients considering or using psychedelics. So it's a way of having a space to talk about that. Offers an ethical and theoretically grounded approach to integrating conversations about psychedelics. So it just gives you parameters, bumpers, and outline. So it helps to focus the conversation, because theoretical approaches can be really helpful and grounding for clinicians and helps them stay focused and feel like they have a roadmap. So some limitations: there's limited empirical evidence and a lack of consensus on standards of practice and training with psychedelics. The future research is needed to establish standards, evaluate efficacy, and explore mechanisms of change in psychedelic experiences. PHRI can be integrated with various psychotherapy approaches and treatment goals. So that's just part of the conclusion, not a limitation. This reduces psychedelic related harm through education and informed decision making, and can enhance the benefits from psychedelic experiences by leveraging mechanisms of action and neuroplasticity. As we know, that is a wonderful benefit of the use of psychedelics.